Hello, I'm Christine Katurba, and I'm a pediatric neuropsychologist at Nationwide Children's Hospital in Columbus, Ohio. And I'm excited to be joining you today to talk about pediatric neuropsychology. So first of all, what is a pediatric neuropsychologist? The American Academy of Clinical Neuropsychology, or the AACN, has a definition on their website. They say pediatric neuropsychologists have training in both clinical psychology and neuropsychology. They have special training in how the brain develops. They use this training to evaluate and help manage and treat children with brain disorders. And this, along with additional information about pediatric neuropsychology, can be found at their website on theaacn.org/pediatric-neuropsychology. So what is a pediatric neuropsychologist? This is a psychologist. So someone with a doctoral degree. This could be a PhD or a PsyD, and it has to come from a program that has been accredited by the American Psychological Association or the Canadian Psychological Association. After completing their doctoral degree, pediatric neuropsychologists complete a one-year internship that's either accredited by APA or CPA. After their internship, they have graduated from their doctoral program, and next they go on to complete a two-year postdoctoral fellowship in pediatric neuropsychology. And it's during these 2 years that pediatric neuropsychologists get additional training in neurodevelopment, child development, and brain behavior relationships. After this, they obtain a psychology license in the state where they live and work, and optionally, they can also complete board certification by a board like the American Association of Clinical Neuropsychology. So what do pediatric neuropsychologists do? Pediatric neuropsychologists help parents, teachers, and physicians, and they help them to understand how problems with the brain might relate to problems that could be seen at school, home, or with peers. So we really try to link what the parent or the teacher or the physician might be seeing day to day, and we try to relate that with what's going on neurologically. We also help those working with the family and the child how to understand how they learn best, how to understand why they might have behavior problems. And then we help a child deal with their thinking or behavior problems. We also identify neurological or psychiatric problems or conditions, and we help match expectations to a child's specific strengths and weaknesses. And this is something that I find myself talking to parents about every day. How can we best meet a child where they are based on the strengths and weaknesses that we determine on testing? And how do we adjust our expectations to really match with where they should be based on a child's specific profile? We also work with other doctors and teachers to develop the best treatment and school plan for a child. So as you will see in some later slides, our evaluation process really helps to make sure that kids and teens are linked with the best services, support, and accommodations to help them reach their full potential and be as successful as possible. What types of kids do we work with? We see children and adolescents, really of all ages. Pediatric neuropsychologists treat very young children, even sometimes around 1 to 2 to 3 years of age, all the way up to young adults. We might see children who are in their early 20s, especially if they're presenting with a childhood condition or disorder that persists into young adulthood, or if they have school-related difficulties at the college level. We also see people when there's concerns for transition to adulthood. So we see a wide range of ages and developmental stages. We work with youth who have learning and cognitive difficulties, a medical condition that could impact cognitive functioning, and oftentimes have unmet needs at home, school, or out in the community. We also work with youth when there's treatment-related considerations. Now, how is pediatric neuropsychology different from adult neuropsychology? The biggest difference here is that pediatric neuropsychologists are always thinking about development, current development, previous development, and future development. So one, where has the child developed from? What types of developmental issues or delays might they have had before they come in to see us? When they do come in to see us, where are they at developmentally? Are are they at an age appropriate level for their functioning? And then 3, how do we expect them to develop over time in the context of the neuropsychological testing that we've done, in the context of their history and their medical condition? We evaluate and assess children and adolescents with a wide range of medical and neurological disorders that can impact thinking or behavior. These could include things like brain tumors, epilepsy, acquired brain injury. So this could be something like a traumatic brain injury, a stroke, infections, encephalitis, that type of thing. Developmental conditions, so things that have been present since an early age or maybe even since birth, and genetic conditions. We also work with children who have things like learning disorders and attention deficit hyperactivity disorder. So there's a wide range of conditions that we treat and assess and use. Now let's talk a little bit about development, because this is a critical part of pediatric neuropsychology. And I included pictures of my son, Joe, here. And as you can see, I am raising him to be a diehard Wolverine like myself. Now, an important note that I should make is that I live in Columbus, Ohio, which is home to the Ohio State University, the arch rival of the University of Michigan. Now, the important point I want to make with including these pictures is that development involves both biologically determined characteristics and learning from the environment and caregivers. So take my son as an example here. I like to think that he is biologically determined to be a Wolverine just like me. And I'm also ensuring that he can learn from the environment and from myself, because I dress him in Michigan clothes as much as possible, in an attempt to counteract any environmental learning you might be getting from Buckeyes in the state of Ohio. Now, when it comes to development, there's different domains. We have physical, cognitive, language, social, emotional, and adaptive. I think these 2 infographics are really, really helpful when it comes to thinking of developmental milestones. Whenever I'm talking with a parent or a caregiver, I'm always asking about developmental milestones. Did they start walking and talking on time? Did they get early intervention services because they were delayed? It's really important to know what a child has done developmentally before you see them, and then to take that into context of what you're seeing during the current evaluation. So as you can see here, development follows kind of a typical trajectory in typically developing healthy kids, where we see kind of simple exploration of the environment, things like cooing and babbling early on before kids start saying the first words. And they start speaking single words before they start combining words into sentences and longer phrases. Development involves a number of different domains: gender, socioeconomic status, culture, family, environment, and prenatal factors all interact together to contribute to overall development. And these are all factors that as pediatric neuropsychologists, we are taking into account. So some developmental considerations to think of include the following. It is important to consider the developmental age and functional abilities of the child. So not only are we thinking what should a typical 7-year-old be doing, but then we're also looking at 7-year-olds that we might be seeing for an evaluation and asking ourselves what they actually are doing and how that fits with what we might expect based on their age. We also must understand both typical and atypical development in order to design standardized procedures to elicit things like command following or verbal expression, purposeful movement. We have to make sure that what we're doing to assess the child is both developmentally appropriate and appropriate for the specific child that we are seeing. We also have to understand the context where development takes place: home, school, community. We have to understand how atypical development can impact functioning differently in each of these settings. So what does a pediatric neuropsychologist do? I oftentimes think of my job as like a detective. So after I've reviewed the referral information, I meet with the family and the patient, and I conduct a background interview. Next, I design the test battery based on the referral question, what I've learned from the interview, and my initial impressions of what's going on with the child. I complete the evaluation with the child and I get rating forms of daily emotional and behavioral functioning, executive functioning, and daily living skills from the caregivers and the schools. I score and interpret the test scores, and I integrate this information with background information, diagnoses, and other relevant information. So it's at this point that I do a really deep dive into the child's medical record, and I'm integrating their test results with information that I'm finding from things like neuroimaging results or EEG results, which can tell me what's going on neurologically with the child. I also am combining information from their background, and I'm looking at school records to see what the school has seen with this child. I look at any evaluations that have been done through the school or elsewhere, and I'm pulling all of this information together. And I use this to form a unique case conceptualization and write the report that has all of this information in it and includes individualized recommendations for the child. Finally, I share the results with the family, the referral source, and the stakeholders. So I mentioned earlier that I put together a full report that includes all this information. So just to give a summary of what is included in this very detailed and comprehensive report, we have the background history. This includes things like the family history, the history of things like emotional or behavioral condition, maybe educational background of the caregivers, pregnancy, birth, and early developmental histories. I pay special attention to things that may have been atypical during pregnancy or birth or early development. Medical history, any diagnoses, treatments, any types of medical test results, school history, current grade, any concern for previous school performance or current school performance, and any accommodations the child might be receiving in school. Emotional, behavioral, and social functioning, both previous and current. And then current functioning. What are the parents or caregivers' current concerns? What's going on with the child that brings them in for testing? And what do they notice in terms of day-to-day functioning? I then include all of the test results. And when we do an assessment, I'm looking at things like overall cognitive functioning or IQ, overall intelligence, language skills, both expressive language and receptive language, visual spatial skills, memory, so both verbal and visual memory. I look at both immediate and delayed memory, and I can assess whether things like recognition or prompts can help facilitate a child's ability to recall information. I look at attention and executive functions, motor skills with both hands, academics, so things like reading, math, reading comprehension, spelling, written expression skills, and then caregiver ratings of emotional and behavioral functioning, executive functioning, and daily living skills. And whenever possible, I attempt to get ratings from schools as well. So while I'm seeing a child for several hours on a given day, or maybe spread across 2 days, I want to get a sense from the people that are with that child the most, what they're seeing with them day to day. When I think about the conceptualization section, I'm thinking about what do these results mean? What does this mean for this particular child? And what do the results mean in the context of their child's history and their medical condition? So if I'm looking at a child with a specific medical condition, like a traumatic brain injury, I'm going to take what I know about other children with a traumatic brain injury, and I'm going to see if this child's profile matches with what I might expect based on their specific injury, or their illness, or their condition or diagnosis. Then I put together a comprehensive list of recommendations that target all of the areas of difficulty that the particular child has. And I structure these for school, home, and then other types of recommendations that might be provided for things like resources or services or referrals that may be made. So what happens after an evaluation is completed? The family shares the results of the report with the school. So this is something that I encourage families to do after they've had a chance to really look over the test results themselves. This can help to get school supports and accommodation. So this report cannot be used in isolation to get school supports. The school will have to do their own evaluation, but oftentimes schools are able to use our test results and recommendations, and they're able to combine that with their own evaluation in determining whether a child needs special support from schools. Then I share results with the medical team, and this can help to make treatment decisions. For instance, if there's a child who's had attention problems and and they come in to see me and I make a diagnosis of attention deficit hyperactivity disorder, I might recommend that their primary care physician discuss medication treatment options with them. So this can be something that I'm relaying to the family and the medical team. I work with the family and the medical team to determine whether updated testing is needed in the future and when this might be. If a very young child has variable test results that are impacted by inattention, for instance, I might say, let's see them back in a couple of years so we can see how they do once they get a little bit older. Or if it's a child where I diagnose ADHD, I might recommend them trialing medication and then seeing them back in the future to see how they do once they're trialed on medication. If it's a child where I expect that they're going to be changing over time, like a child who's recovering from a severe traumatic brain injury, I might recommend seeing them back in 12 months or maybe 2 to 3 years. If it's a child who's expected to have continued developmental difficulties, I might refer them to be seen again during the transition, like 3rd to 4th grade, from elementary school to middle school, or from middle school to high school. I also make referrals for other services and supports. So if a child has behavior problems or emotional difficulties, I might refer them for behavioral health services and talk to the family about what this could look like. So thank you so much for your attention today. I'm more than happy to take questions. If anybody is interested in learning more about pediatric neuropsychology, I included my email here on this last slide, and I would be happy to answer any questions that come up about pediatric neuropsychological assessment, or if you're interested in learning more about what I do as a pediatric neuropsychologist.